Over to Dr. Ravi.
Thank you. Namaste and namaskar and good morning, dear friends, respected seniors, teachers, colleagues. It's so nice to see you. A big crowd in front of me. Haldipurkar sir, namaste. Thank you. Wonderful masters sitting in front of me. I'm a young guy trying to present these techniques to you at the 40th Asia Pacific and the 83rd Annual Congress of All India Ophthalmological Society. Thank you. Slide.
Next slide, please. It's not advancing. Yes.
Yeah. Happy to be among the stalwarts who are presenting here. And thanks, Professor Dr. Mohan Rajan, for allowing me to be the co-instructor in your course. Thanks a lot. And no financial interest in any of the products, techniques, or the instrumentation spoke or demonstrated in my presentation over here. There are many ways to skin a cat, and the secondary IOL, there are many options, and I would like to say that it depends upon the amount of capsular support or the nil capsular support. You can select any of these, and whichever technique is good in your hands, I would suggest to go for it. Anyway, I'll be talking about only 3 techniques over here, but you have the ACIOL, the iris cloth, the scleral fixated lens, Professor Amar Agarwal's glued IOL, the flanged IOL technique, the Yamane technique, Dr. Nivian's CMT flex, and XNet from Aravind Eye Hospital. I would always try to talk to my talks always to the beginners and the younger ophthalmologists, because stalwarts have done many surgeries. They can manage and do the surgery at the end of the day fantastically. But for the beginners and the younger ophthalmologists, all these prerequisites are very, very important. A clean, thorough vitrectomy, which was even emphasized by my previous speakers. Triamcinolone acetate is very, very important when you do a vitrectomy. The reason being, gone are the days when you use a cotton bud over the wound area or try to swipe a spatula on the pupillary margin to see if any vitreous is there. Cannot. Triamcinolone acetate is very, very important to visualize the vitreous and the vitreous strand and the vitreous bodies. And every technique has a different micro instrumentation, and very important to have and getting trained in that particular micro instrumentation. A standby IOL is very, very important, because I've seen many of the trainees, when they are trying to learn a technique, the haptic optic junction breaks away. So have a standby IOL definitely with you. A chamber maintenance is very important. A pars plana trocar cannula, of course, very important when the eye is not vitrectomized. And an AC maintainer, when the eye is already vitrectomized, you can have an AC maintainer. I'm talking about the flanged IOL technique, the Yamane technique, and the XNet. The Yamane technique was already shown by my previous speaker. In the flanged IOL technique, the corneoscleral incision is made. A good pocket is opened up for the IOL entry over there. 2 stab incisions are made on the either side, and a good vitrectomy is done to remove all the vitreous from the anterior chamber over there. And a needle which can be a 6-0 Prolene or a 7-0 Prolene injected and entered inside the eye on either side. And with the other forceps or the beveled cannula over there, insert the needle, try to pull it out through the stab incision. Likewise, on the other side, insert the needle in the cannula and try to pull it out. And you can try to crisscross that sutures over there. And once it is done, you can flange the IOL like this in one of the eyelets, and by a monopolar cautery, try to flange it over there. If you can watch on the either side, see how it goes. There's a bulb or almost like a micro lollipop over there, and then insert the IOL inside the eye. And once the IOL is there inside the eye, you can titrate with both the ends of the sutures on the either side for the centration. And once you're sure that your IOL is centered and you've titrated better, cut the suture and with the monopolar cautery, flange it over there on either sides. This is a flange technique. And once you've flanged it, and once then you can just try to tuck inside that groove over there, and your surgery is done, and the IOL is well centered. And this is the Yamane technique, which I don't have to talk much, because Many people know about the technique already. The very small video, make both entries to the needle. The needle itself holds as a scaffold for the IOL over there. Use the trailing haptic and get it inside the needle and gently pull it out. Likewise, on the other side, use the needle, enter inside, and feed the haptic inside the needle, pull it out. Be gentle in your maneuvers and procedures, and then with the monopolar cautery, try to flange it on either side, and that's the end of the surgery. Looks pretty easy, but all the maneuvers needs a lot of steep learning curve to work on them, and once you're ready with the IOL centration and your surgery is done. This is the X-nick technique which I would be very happy to present over here. Technique devised by the Aravind Eye Hospital, Dr. Prabhu Bhaskaran. You make 2 side pockets and 3 and 9 o'clock position and make the corneoscleral tunnel for the IOL to enter. You use the trocar cannula for the vitrectomy, like all the previous speakers also was very sure. A good vitrectomy is very important. Even a nuclear bit over there can be removed. Even an IOL which is dangling or which is on the macula can also be removed. And there's a 26 gauge needle which is bent at its hub. Enter 1.5 millimeter away from the limbus, go inside, and with your right hand hold the McPherson's forceps to depress the wound over there, and with your left hand try to turn your 26 gauge needle. There it comes out. That's why it's called X-nit, because it's an extraocular needle insertion technique where you don't have to have the difficulties of an intraocular the suture insertion or the haptic insertion. There goes the haptic, trailing haptic inside the bevel, inside the tunnel of the needle. Gently with your right hand push the intraocular lens inside, and simultaneously with the left hand pull the needle outside, and your IOL is there inside, and push the silicone tab over there into the limbus area over there, and there your haptic is out. And likewise on the other side or the other position, insert the 26 gauge needle, depress the wound with the McPherson's, hold the trailing haptic, tuck it inside, feed it inside the bevel, inside the tunnel of the needle, and gently. This is extraocular needle insertion. And there comes outside. Once you're out, be cautious to hold with the McPherson's the haptic, and then remove the IOL outside. And once it is done, you can just tuck in the haptics into the pocket on the either side. As I told you in the previous case, looks pretty easy, and good steep learning curve. Once you start doing a couple of cases, life becomes easy for you, and the patient in fact has a good vision at the end of the day. Chief Instructor, do you have time for one more video? If I have time, if not, I can just...
We have time.
Yeah, this would
You
be
have another almost 2 minutes to go.
This is my last video with the X-nick technique. There's an IOL drop over there, IOL sitting on the retina over there. Hold it with your microforceps, gently pull the IOL outside and bring it out to the scleral wound. And then the rest of the things is what the previous video I showed you with the 26 gauge needle. There comes the needle out, the haptic, the trailing haptic feed it inside the tunnel, and gently push the optic IOL inside, and with the other hand pull out the needle outside. This is the same technique which I showed in the previous surgery, and likewise in the other side also do the same thing. And once the haptics are out, you just need to push it inside the pockets, and there it stands safely for life. That's the end of the surgery, and thank you so much for the wonderful opportunity, Chief Instructor Professor Dr. Mohan Rajan, and all the co-instructors and all lovely delegates who were patient enough to hear me in this talk. Thanks a lot.
Thank you, Dr. Ravishankar, for the wonderful talk. I think you summed it up in the sense that the flanged IOL, like a Yamane technique, or